All right, next chapter is on oxygenation. And anytime you start about oxygenation discussion, you need to always go back to the oxygen dissociation curve. You should know this like the back of your hand. You have to know this for the rest of your career and the rest of your life. This curve is basically designating to you what happens with the hemoglobin and its binding capacity to oxygen. This actual curve shifts and changes all the time. And there's three axes that you got to pay attention to. The axis in the bottom is the PaO2 axis, which is how much oxygen is dissolved in the plasma. The saturation is how much oxygen is bound to the hemoglobin. And then the concentration is the CaO2, which is, of course, the hemoglobin times the saturation. Okay? So if you see somebody's drop in hemoglobin, the actual content will fall, but their saturation will still remain at 100%. So this number will fall with it. Okay? So content decreases don't necessarily are indicated with desaturation. Okay? You can still have somebody with a hemoglobin of 2 or 3 and still be 100% saturated. Okay? It doesn't mean they have enough carrying capacity, but they do have 100% saturated hemoglobin. Okay? Now, one of the things that you got to pay attention to in this line down here is this is the dissolved oxygen. See this little dashed line in the bottom? This is part of the equation that we talk about, which is the, what's it called? Yeah, just, okay, remember that guy? Okay. This portion here describes this, down here, this dissolved line. So you can see it's not significant. This part of the equation is insignificant for carrying capacity. The dissolved amount does not matter. You could have somebody on high FiO2s and the person will be dead without hemoglobin. Okay? Now the oxygen dissociation curve also tells you how the truck reconfigures. Okay? It goes into the right and left shifts. So this is our normal. Say this is a person. What you're seeing here, this is what would be your blood gas. Okay? But at the tissue level, this actually curve will shift downwards like this. Okay? So this person's, what will happen is the hemoglobin will unload the oxygen. Okay? So that's what you want. If you drive the other thing, which is make the person more alkalotic, your start point will stay up here. So that person has a higher binding capacity to oxygen, which then doesn't deliver it well. That blue line would be a good indication of fetal hemoglobin. Fetal hemoglobin tends to do this as well. It doesn't deliver oxygen to the tissue as well. Okay? But the reason it's doing that is why? Why would be the benefit of having fetal hemoglobin? That's right. You have these two guys, two different truck companies, going right beside each other. Okay? And if they were the same line, they wouldn't transfer any oxygen across. But one has more of a greater affinity, so it begins to extract the oxygen off the very effective carrier mechanism, which is moms. So this extra oxygen here that is carrying is basically removing the oxygen off the mother's maternal hemoglobin. Okay? When it gets to the tissue levels of the baby, because there's so much more acidosis in a baby, it shifts way over and unloads it just fine. Okay. All right. Now, one of the things that is not drawn very well in most textbooks, and most students don't really understand this by looking at this, so I'm going to sort of show you another way of looking at this. Okay? When you're looking at the oxygen dissociation curve, most people don't see what's beyond this point. This point has to do with this value here, 600. But look at this line here. What does that mean to you? What does that double dashed line mean? Okay, here's what it's going to mean. Okay, just think about it this way. Okay, this is my curve. Okay, but instead of being 100 here, now it's 200. 300, and it goes all the way to 600. Now, why is that important that I'm showing you this? Why? Who cares, right? What is this line telling you? What is that line telling you at that point? That person is going to be what? They're going to be 100% saturated. So saturation does not tell you how much PaO2 you really have. You have no clue where you're at unless you draw blood gas. Okay, and that's what we call the AA gradient. Okay, the alveolar, which is the expected value, to the arterial PaO2. Okay, so if you have somebody on 100% FiO2, okay, which means that their PaO2 should be 600, and now let's say you drop the lung down. Let's say you collapse one lung. You've main stem intubated the individual. And now you're only at 40% of lung function. You're still going to drop down to here. And PaO2 is going to be at 130. Are you going to notice any difference on your pulse oximetry? No, not at all. And that's the danger of going to high FiO2s. You're taking an ability for a monitor, which is pulse oximetry, can be used as a monitor to tell you how much ventilatory function you have. And now, because of this extended plateau phase, obfuscating the problem, that it's no longer an effective, useful monitor for if you've main stem intubated the individual. Okay? The only time you may pick this up would be if you're under 50% FiO2 or less. Then you will pick up the saturation will fall, because then that individual, instead of being, let's say, at 300, now they drop down to here, and the stat begins to fall. That's why we try to teach you, don't go to 100% FiO2 all the time, because you're really going to lose the monitoring capability if you've main stemmed intubated the individual. If you're really good, you might pick up that the CO2 is actually falling on you. You know, the CO2 will actually be lower than you expect. Well, when you draw the blood gas, it's actually sky high. Okay, because now you're ventilating only one lung. All right. Now, there's various responses to hypoxemia. Hypoventilation is easily reversible by additional oxygen, so is diffusion impairment and VQ inequality. The only one that doesn't reverse very well with oxygen is shunt. Okay, so you have to know that. That's like 3 times I've said that, so that should be like jumping out at you. Big test question. Okay. What you look at here is this is an individual that shows you 2 examples in the book. Initially, when I looked at this, I didn't quite understand what they were getting at until you sort of has to be explained a little more thoroughly. Which is if you look at A is a normal individual at sea level. Okay, so this individual is in Naples. Okay, and B, that individual is up in Colorado, Mile High. Okay, and his PaO2 values, which is the alveolar values, have significantly diminished. Instead of having a PaO2 of 100 in your alveoli at sea level, as you go up in altitude, there's less and less oxygen available because of lower pressures, so your PaO2 falls down to around 50. Okay? This person, as long as they're walking around under normal time and their actual speed of the capillary is at 0.75 to all the way to 0.5 seconds, the person's still 100% saturated, still doing okay. But if you make them work strenuously, like trying to climb a mountain, okay, so you're up there in Vail, Colorado, which I've never been to, going out skiing, okay, if you start walking up the mountain, you start doing heavy exercise, then your PaO2 volumes will fall and your saturations fall. Okay, that individual becomes symptomatic at that point. Okay? If you have any form of abnormality, which is what the other 2 lines are for, they will be okay at rest for this person who's not significantly impaired, enough impaired that as soon as they do exercise, they become, they start desaturating and becoming symptomatic. And the person who's grossly never reaches full effectiveness of oxygen uptake, and the consequence is already impaired even without exercise. Okay? These are what we're trying to show you. There's other methods of oxygen delivery that we can measure. Arterial PaO2 is a good idea about how much diffusion is taking place. Of course, what we care about when we're talking about how oxygen is delivered is how many trucks we have. So hemoglobin is critical. And people can become very symptomatic really quickly, even though they can be 100% saturated. You can actually look at somebody and see that they're having trouble because their heart rate becomes to increase, their work of breathing begins to increase, okay? And simply could be from low levels of hemoglobin, okay? When you look at the actual carrying capacity equation, which is 1.39 times the hemoglobin times the saturation, the most important value here most of the time is hemoglobin. As long as you maintain the person 100% saturated, it's not usually a problem except for the drop in hemoglobin. The PaO2 here value, because of this variable, is 0.003, means that most of the gas that gets into the plasma never gets to the tissue, so it becomes irrelevant in most equations. If you take this out, it would not matter clinically at all, so this is what we use clinically. We use the 1.39 times the hemoglobin times the saturation value. If you look at the actual delivery, how much oxygen actually gets there depends on not only the carrying capacity, but on the actual cardiac output. Okay? So if you have a low cardiac output state, but still adequately saturated, it doesn't mean that the tissue is going to get enough oxygen to it. Okay? You need to get the delivery to get there. And the oxygen dissociation curve, remember, when it gets to the tissue level, we talked about this last hour, it shifts towards the right, causing the hemoglobin to unload and to give up the oxygen. Eventually, the oxygen goes from the capillaries to the mitochondria, which is a very short distance, and then is important in oxidative phosphorylation, which is the production of high-energy ATP. Like craziness that you'll see, and I saw this at one of the places I went for an anesthesia conference, was they actually had oxygen bars, and I was very curious as to why they were doing this. And this was at altitude. This was actually at sea level in California, so I'm going like, why are you doing this? And said they improves your health, bogus, it doesn't do anything. And they actually made it with scented different smells to it. So that's very nice. Oxygen with smell to it. Like water is not good. If it wasn't tasting with a little bit of extra stuff, water's not good enough in itself. I guess now oxygen's gone to the next level. I guess for all of us, we're going to be now walking around with oxygen tanks with scented oxygen tanks. That's the next level. Who knows? Yes? Did you get to enjoy it? It's a waste of money. It's a waste of money, let's put it that way. Plus, you don't even know what you're inhaling. Anything that smells, you might necessarily be a toxin in your lungs, so it may not be such a smart idea. Okay? But they had different oxygen-scented smells, which was like, okay. Most of the tanks that we see now are basically E-tanks, which are used, and then the smaller ones that are used at home. And people can put on nasal cannulas for a prolonged period of time with little nasal cannulas because they now have regulators on them that as soon as the person breathes in, they'll get a little bit of squirt of oxygen instead of being a continuous stream like we're used to in the ICUs and the ORs, and as well as in the floors. We actually waste a lot of oxygen, okay, because we don't have regulators on our oxygen. Okay, when you put on oxygen to somebody, you put them on 3 liters per minute. That means they're getting continuous flow of 3 liters per minute. When people do that at home, their tanks would empty out in a few hours, so it's not effective. So they had to put it on them as a regulator mechanism that senses when they breathe in, and then the oxygen would just get squirted in. So it saves a lot of time. It saves almost 60, 70% of the breathing that is exhalation. There's no point in giving that person oxygen during exhalation, which is what we waste all that, which is okay. So these are nasal cannulas. The bad thing about nasal cannulas is they're low oxygen flow delivery systems. And the reason that's bad is because it does not pick up well hypoventilation. If you have somebody who's hyperventilating, FiO2 goes up uncontrollably. Okay? If you have a person breathing normally, though, if you have for every 1 liter of oxygen, it's a 4% increase in FiO2. So when they ask you that in a test question, how high can you go up? And the answer is around 40% is really the maximal FiO2 that you can achieve. Okay, once you get above really 8 liters per minute or 6 liters per minute, you're wasting gas. It's not doing any good. But if you have somebody who's hypoventilating, on the other hand, you can go reach FiO2 as high as 1, which is 100% FiO2. Not something you really want to do. So if you have somebody this is what the danger is. Somebody that's on a pulse oximetry monitor, right? And then they're given, the nurse notices that the saturation's fallen a little bit, okay? But hasn't noticed that the person's breathing rate has gone from 16 down to 12 because the person has duromorph in their back, okay? So then they decide, well, I'm going to give nasal cannula, so we resolve the pulse oximetry issue, okay? So she puts nasal cannula on the individual. Okay? Well, she notices and she walks by the room and doesn't decide to check the breath sounds because, you know what, my pulse oximeter is telling me the person's breathing fine. So they keep walking by for the next 3 or 4 hours, and the saturation is still 100%. And the person's on 4 liters of oxygen. Okay. What she doesn't know, or he doesn't know, is that the person's respiratory rate every hour has dropped by 2. And now this individual is only breathing 2 times per minute and is about to arrest on her or him. Okay? And when you track back what's happening is that now the FiO2 is 100%, and even though the person's breathing 1 to 2 breaths per minute, their CO2 is in the 80s, 90s, so they appear asleep and comfortable, but they're actually about to die. Okay? And then what happens, as soon as they stop breathing, then the saturations fall like a rock. And then you have the code. And people go like, what happened? What happened was nobody was watching the respiratory rate. Okay? Respiratory rate is critical if you use pulse oximeters and use low-level oxygen systems. If that person was giving a fixed Venturi mask, then it would be, she would continue to desaturate because the Venturi only would deliver a certain FiO2 max. It would only go above 40. So the nurses would notice that the saturations would start to fall because as hyperventilation would get worse, the FiO2 wouldn't be getting variably increased. Okay? This happens not only on the floors, but it happens in our recovery rooms. So you got to be really watchful of nurses. If you ever have somebody arrest on you, and they tell you, well, you know, the saturation was okay the whole time, the first question out of your mouth should be, what was the breathing rate? And a lot of times the nurses will look at you, they're honest, and say, well, I wasn't really checking that. And what they were doing is they were giving more and more narcotic because the person was complaining. And they noticed that the person started less complaining and now appeared to be sleepy and looked really comfortable. Yeah, you look really comfortable at CO2 of 80 or 90. And you will arrest with enough time. Okay? So that's an important point. There's also low-flow masks, which I don't use, because the reason they retain CO2, so that's why I don't like them, because it becomes dead space. It increases the dead space. So that mask retains CO2, so I don't use low-flow oxygen masks ever. Okay? Patients do feel more smothered, and it can increase the FiO2 as high as 60%. Instead, what I use is high-flow systems like this, Venturis. Okay? Venturis have air that entrains through the actual circuit. Okay? And it gives you a fixed FiO2 no matter what your respiratory rate is. And then you have, of course, your optimal maximum FiO2, which is a non-rebreather mask. A non-rebreather mask basically gives you 100% FiO2. Okay? I'm really very crazy about some of this stuff because I see people making clinical errors all the time with this stuff. They don't understand the mechanism of some of these equipments. Okay? And unfortunately, in our job, we're not just theoretical. Okay? You can know all the theory you want, but if you can't apply anything, you're useless and you're actually dangerous. So you have to have practical knowledge when you do this job. So when people tell you you need to apply oxygen, you need to know the difference between a low flow and a high flow system. Okay? How much FiO2 you're delivering. Okay, so when you draw blood gas, you know what the value should be. So that way you can get your AA gradient. Okay? And when should you use which ones and which ones should you not use? If you have a reasonable concern about somebody hypoventilating, then really a nasal cannula is a very poor choice. Okay? If you're concerned about that, then you're better off with going to high flow systems like Venturi mask. Okay? If you have a reason that you have to put somebody on high oxygen levels, then it makes sense to give them 100% non-rebreather mask. Okay? Now, where the limit becomes is some people will tell you, well, I'm going to pre-oxygenate somebody. Okay? See if I got this one, next one. This is what a Venturi gas. Okay? The Venturi basically is a reliable oxygen administrator. It doesn't really retain any CO2 in the mask. Okay? Because it's such a high flow system. And what the Venturi basically does is it ejects the oxygen at a very high flow velocity and then entrains water. Not water, but entrains air from the environment in. Okay, this is a Venturi describing fluid Venturi, but in a sense, this is the same as in the oxygen Venturi mask. What this is doing is the oxygen is flowing at high velocity here, and these portholes on the side is where the air entrains from the environment, giving you a fixed FiO2 value based on the flow rates that you're delivering. So you can change two things. You can actually have variable Venturis where you can actually change the hole size and it'll tell you how much flow you should be delivering. So you got to pay attention to flow of what the oxygen is set at, and then you open it up based on what you want, how much FiO2 you want to get into that patient. This is where I was trying to get at next, okay, which is the mask that we use, which is 100% non-rebreather mask, is specifically designed for allowing a person who's spontaneously breathing not to have retention of CO2, and also has a reservoir space that has no valve in it. It's got a little valve, but the valve, as soon as you're taking an extra breath, that valve is so weak that it opens up immediately and empties out that extra container, which is oxygen sitting here, to let the gas into the patient. So the person has no really increased work of breathing with a 100% non-rebreather mask. They don't work harder. But on the other hand, if you take somebody and put them on an ambu bag is not designed to pre-oxygenate you. It is not. It's not built for that. An ambu bag is built to mechanically ventilate somebody. And in that, it's limited. It's really actually terrible if you think about it. The maximum you really can deliver with a ambu bag is around 500 cc's. It sucks. Okay? If you're trying to do an adult that wants 1,000 cc's, you're not going to be able to squeeze that bag hard enough to get 1,000 cc's into them. So it's kind of a crappy bag for that. Okay, that's why our bags are much better, because our bags have 3-liter contents. So if we want to squeeze away, we can really pump a lot of air into the patient. Okay, and you can feel the difference. An ambu bag, you will have no compliance issue. You have no way of knowing what the compliance of the lung is. When you squeeze that bag, I don't care if you're squeezing it on the table, you can't tell the difference. Okay, it's really not a good system. Versus our bags that we use in anesthesia machines, as soon as you squeeze a bag, you're connected to the lung, and you can feel the difference. You know when the person's tight. You know when the person's open. Okay? Versus with the ambu bag, you're really not. Okay? One thing that drives me crazy is that you'll see people pre-oxygenate using an ambu bag. They'll put the person's face on and they'll tell them, breathe deep. And the person is actually suffocating. And they're actually getting hypercarbic as well. The only way they can open up the valve to get oxygen in is they have to forcibly open it so their work of breathing goes right to the roof. So if you want to pre-oxygenate somebody with that, you've got to squeeze the ambu bag while the person's breathing to open up the valve properly to get oxygen in to the patient. And most people do not like the ambu bag because they feel like they're suffocating. They can't exhale out properly as well. They can, but it's difficult. Yes? I think 60%. Yeah. I have to look it back up again, but I think it's like 60%. Once you get above that, you're going to 100% on a breather anyways. Okay, so what I want you to make sure you understand out of this is don't use the ambu bag to pre-oxygenate somebody. Do people do it all the time? Absolutely. Is it wrong? Absolutely. Okay, how many people have seen somebody do a procedure on somebody and they immediately put an ambu bag on them and then try to pre-oxygenate them? Okay, it doesn't work. Okay, because I can prove it to you, but as soon as the person goes to sleep, what do? They desaturate like a stone. Okay, how many people have seen them desaturate right away? Okay, so I've got some shaking heads. So, that's why it happens, because people think that they're oxygenating, but they're not. Okay, if you want to pre-oxygenate somebody, use the Venturi mask, or you put them on the anesthesia circuit. That's the proper way of doing it. Okay. When things get really desperate, you can do what's called transtracheal oxygenation. Okay, almost all the anesthesia departments in the United States have this device. What we do is we usually will put in a 20 or 14 gauge needle through the cricothyroid membrane, and then hook it up to a device that looks like this. It has actually attached to an oxygen tank, and then we have this little device here that is used to fill up tires. That's where actually the design comes from. It doesn't come from any fancy respiratory department. It actually came out of the auto industry. Okay? Yeah. Anything in anesthesia is practical, again. Okay, so you go find it. You don't have to invent the wheel. You just go find somebody who already invented it and you just modify it to anesthesia. So they added this device, and then you hook it up to your 20 gauge or 14 gauge angiocath that's in there, and then you squeeze it as fast as you can. And you're basically shooting oxygen into the patient's trachea. Now, this device is great as long as you're only trying to oxygenate the individual, which is fine. By that point, you're trying to intubate them. Okay? You continue trying to intubate them because this is not going to ventilate. If this person has a supraglottic tumor, what's going to happen? In other words, the larynx is completely collapsed above the portion where you just put the transtracheal jet. What's going to happen to the lungs? Right, they're going to do eventually. Pop goes the weasel. Okay, so don't do that. Okay, so if you have somebody with where you see the chest is going up and not going anywhere, not going out, you hear no exhalation, stop. Stop. You can just let the lungs go back down. The chest will go back down. You can ask yourself, well, where's the gas going, right? How's it going back down? It's going to your bloodstream. The blood's sucking it up. Okay, but what's happened to your CO2 levels? They're going through the roof. There's no way the CO2 can come out, so the person will become CO2 hypercarbic. But at that point, it doesn't really matter. Just keep oxygenating them. If you see the chest wall rising, just stop. Now your tanks are full of oxygen. Just wait it out for a few seconds as you proceed to go to the next step, which is usually doing a trach. You're doing a tracheostomy in that individual. Okay? We did this the other day. Actually, I had an individual that came in that had a subglottic mass that was 99% occluded. Okay, and he said for the last 3 weeks he couldn't breathe, and he came into the emergency room with saturation of 68%, and CO2 was like 58, and was not really moving any air. So the way we resolved it was we put BiPAP, pressurized him above, opened up the larynx just enough to get some air in, and then we did an awake trach, totally awake, with local anesthesia. And I gave him 1 milligram of Versed, and that's all he got. And remember one thing, I can keep telling you, it's always better to have a bad memory than no memory at all. If you try to sedate that individual and they stop breathing on you, if you try to induce them and try to intubate them with a 99% occlusion, you're not going to get the tube past that occlusion. So you need to get a surgeon to do a trach. The trach actually had to be done low. It was down here. We usually do the trachs a little higher. You had to go low because the tumor was actually above it. Not a good place to be, let's put it that way. You had a question? Which one? Yeah, some people use that, but nobody uses the ambu when you do that. You can actually use an ambu to hook it up if you're desperate. What you do is you actually take a 3 cc syringe and you hook it up to, I think it's a 7.0 tube, the portion of the top of the endotracheal tube. You hook it up to it. That connects up to the 3 cc syringe, and then you hook that up to your angiocath. So it's a modifiable how you're doing it. Okay, I'll show you guys how to do that. I'll bring it out and play with it because you always forget the right size. What you do is you pull out all the tubes out, you just keep jamming until one works, and then you put it together. Okay. I can never remember. I have bad memory about that stuff. I don't like being here. Okay. If I get here, I failed somewhere along the road. Okay. I try not to get myself in that position. Okay. I will rather do anybody awake intubating them than do this, because this to me is that you got so cowboyish like that you got super aggressive and you got way ahead of yourself. Okay. Sometimes you get into trouble, but you try to avoid this as much as possible. You should not have done 10 of these already in your career. If you're doing that, that's really not good. Okay, you're doing something wrong. Okay, I've never done one. I've seen people do it, but I've never had to do it myself. Have I done Crikes on people? Yeah, I've had to do like 3 in my life. But and the last one I had to do was about 7 months ago in the ER. And supraglottic tumor, nobody could intubate. I looked down, I couldn't see anything. It was actually not a supraglottic tumor, it was a supraglottic anaphylaxis. The whole throat closed down. So we did a same technique, just put a needle into the cricothyroid membrane, pass a wire through it using a Cook insertion catheter. Then you take the dilator with it, you make a small scalpel incision, and you just push, and you're in. Pull out, and then you ventilate. And the person immediately resaturated 100%, but it was too long. The person had been down in the field for about 10 or 15 minutes. So unfortunately, he never woke up. But at least we got our secured airway pretty quick. The problem with it is that none of these kinds of crikes have secured cuffs. So you're basically an uncuffed tube. So these people are at risk for aspiration. And there's not much you can do at that point. You're just trying to keep that person alive. Airway comes first, breathing comes second, and aspiration is high on your list, but it's not the highest. highest is getting the tube in. Then you can have oxygen tents. Oxygen tents are really notoriously dangerous. I think you'll never see these anymore. You might see this in pediatric units still. I'll tell you why we don't see them in adults. We had one guy, we call him Puff the Magic Dragon. The reason we call him this way was because he kept stealing, actually his family kept bringing him in cigarettes. And he was in an oxygen tent. And we kept telling him, said, you can't bring in cigarettes. So what he did was he forgot to shut off the oxygen one time and went back in the tent with oxygen and with a cigarette in his mouth. And all of a sudden we hear an explosion. And the whole room disappeared pretty much. And we got called for a code, and I arrived there, and he was burnt up. It was mostly flash. It was rather impressive. And when I opened up his mouth to intubate him, black smoke came out of his mouth, like a little, like a nuclear bomb explosion. A little mushroom cloud came out. Yeah, it was kind of okay. And then everybody sort of said, "There's Puffy the Magic Dragon." So we intubated him. Everything was carbonaceous inside of him, all the way down to his lungs. We intubated him, and then he got alveolar proteinosis pretty quick, and died on us about 6 to 8 hours later. So not a good idea. Don't take cigarettes into an oxygen tank. Okay? The other place where it's very, very dangerous in the hospitals is in the hyperbaric chambers. Okay, some people will actually commit suicide in hyperbaric chambers. They'll take a big cigarette with them. They'll get into the hyperbaric chamber and then light it and explode and kill everybody in there, and including the wing of the hospital will sort of disappear. They've had several reported cases of that happening. So one of the things that you always do before you take a patient in there is you almost strip search them and make sure they're not carrying anything. One of my friends that was a respiratory therapist and was doing research with me had an event like that happen to him, and the guy pulled out the Bic and was threatening to flick the Bic. That would have been a terminal event for all of them. So they did emergency decompression to vent the gas, so he blew his both eardrums in the process. Because the guy freaked out inside the chamber that was controlling it. He hit the emergency decompression button. So he blew out both his ears. The other guy's ears blew out too, which is why he dropped the Bic. So, which is kind of, guess, was the right thing to do. So I guess nobody wanted to die that day. This is what I was talking about. Imagine putting this thing with 100% FiO2 or high FiO2 and then lighting this suck up with pressures of 600 or higher. It would not be a good idea. I mean, high pressures like 1,500, 2,000. So it would not be a good day. And you can see it. You know why they have all these windows in? Because the way these things were designed is that they actually, this wall is actually constructed after they put this device in. So these are very, very large units that are put into the hospitals. And the rooms are not, they're not reinforced for protection if anything terrible happens. So if you're above it or beside it, not good things will happen to you as well. So, but it's a really good therapy when it works. Indications for hyperbaric oxygen is carbon monoxide intoxication. Although most of the time, if you have somebody carbon monoxide and put them 100% of FiO2, by the time you've actually called in the team and got everything done, the person's usually already resolving. Okay? Because it takes that long for a hyperbaric chamber to be set up. Where really the hyperbaric chambers really work pretty well medically is for things like Clostridium gas gangrene. It really works. It really reverses the effects. These bacteria don't like oxygen. They don't do well. Arterial gas embolization has also been very effectively treated with compression therapy. Decompression sickness, of course, somebody who goes diving. This is critical. So Miami has a big decompression chamber. When there's any accident in the Caribbean, they bring these people up. And as you can imagine, what the logistically difficulty of bringing somebody up from the Caribbean, what do you have to do to the airplane? As soon as you go up in altitude, what's going to happen to the patient? They're going to get worse. So they actually fly low. They fly 100 feet to 200 feet above the ground, all the way back. Not something you want to fly in. I had one time we flew with helicopters, and they took us down to skin level, which meant that they were skimming the water at such a high rate that the actual bottom of the Huey was almost touching the water. And I sillily asked the pilot, well, what happens if the skid touches the water if a wave hits it? He says, don't worry about it. He says, if it does, we'll be dead instantaneously. That made me feel real good. I said, can you go up and hide a little bit? Nah. It's fun this way. It's like, 18-year-old pilot, okay? I was 14 years old. It's It's kind of stupid. They were trying to impress us, of course, but they didn't impress me at all. I thought that was kind of silly. Sudden deafness can also occur from, can be treated with hyperbaric oxygen. Okay? People that are refractory to infections like osteomyelitis or seem to be responding to hyperbaric oxygen therapy. Thermal wounds have also been improved, and sometimes grafts and flaps have also been improved with hyperbaric oxygen therapy. Okay? There you have domiciliary portable oxygens. You'll see these patients will have these at home. These are the ones that have regulators attached to them. This is how they actually will refill their oxygen tanks at home at night. So you'll see this in Naples, almost nowhere else where you see something like this set up. These are too expensive otherwise, but people that have money will purchase theirs instead of having it delivered every day or every other day. So they actually have their own machine. And it actually becomes important when you're having a person like that's in hurricane weather and they lose power and they have nobody to deliver for 2 or 3 days. It can become life-threatening for them. So some of them will purchase that for this. The hazards of oxygen therapy is really kind of something that's not talked about. Is anything you get above 50% oxygen, if you give somebody greater than 2 days of 100%, greater than 50%, you start developing oxygen toxicity. What oxygen basically is it'll cause damage. It causes oxidation. If you don't believe that, then why would you take your car into a desert and then go up high in altitude so it doesn't rust? Okay, because what you're dropping is you're dropping oxygen levels. Okay, if you want a car to rust really quick, put 100% oxygen around the car and watch it rust. It'll be rusted completely to pieces in about 3 months. So high oxygen environments are really not something good. Okay. One of the things that also will happen to any animal that's exposed to high levels of oxygen is that it has to have certain enzymes in it to protect you from oxygen toxicity. Okay, so some people are more likely to get oxygen toxic than others. There's still some genetic variability on it. Where you also see problems is that oxygen, when you pre-oxygenate somebody, yes, is it giving you greater safety by the time duration to intubation, which is why we do it? Yes, that's why you're giving it. The downside to it is, just like I told you before, when you give that high oxygen and you see the chest wall expand, then it re-collapses down. Well, where's the oxygen going? It's going into the bloodstream. Well, that alveoli is collapsing now completely. The nitrogen that normally is in air stents your alveoli open and keeps them open. So when you put a high FiO2s, you're basically allowing certain portions of the alveoli to completely collapse and go to atelectasis. So it gives you a greater VQ inequality when you develop this as well. The other thing where you have to be really careful is in kids, you can get what's called retrolental fibroplasia. And the answer to that is that you have to keep the PaO2 levels below 140. So if you have to go increase your FiO2, it's okay as long as you draw your blood gases and keep the PaO2 less than 140. That's what matters. Okay, why 140? What's the critical value about that? Is that it increases capillary hyperplasia. So the capillaries increase dramatically in number and in volume. And if it happens in your eye, it blinds you. It just leads to complete blindness. So you don't want, in the old days when people used to put 100% oxygen in a little kid that was born prematurely, all these kids were waking up, they would be blinded because of this retrolental hyperplasia. So that's why they've become really kind of say, okay, drop the FiO2 down as low as possible. So most of us would only give an FiO2 of 30% or less. Now the big issue is where does it become damaging? And the answer is it becomes damaging if you're not delivering enough oxygen either. I mean, if the person needs more FiO2, if a kid needs more FiO2, is it going to injure them by giving them more oxygen? The answer is we've been found to be no. So as long as your FiO2 goes up, but your PaO2 stays below 140, the kid doesn't produce retrolental fibroplasia. So you got to be really aggressive about watching the PaO2, not watching the official FiO2. The other thing they used to teach us was only don't let the FiO2 go up, but the kid was saturating at 70%. And you drew the blood gas and the PaO2 was only like 51, 52. It's like, wait a minute, we're killing the kid's brain, but we're keeping his eyes perfect. Man, what are we doing here? So we started going up in the FiO2 and found that the kid's eyes didn't go out either, as long as we just watched the PaO2. Okay? Does that make more sense? Yes. What's that? We would actually draw it pretty frequently. Every time there was any kind of change in the lung compliance, we draw blood gas on these kids. A lot of times we had an umbilical artery catheter in, and we were monitoring the kids pretty closely. Some of the places I worked at, we had constant PaO2 monitors. We actually had a catheter inside the A-line that was telling us the PaO2 values of the kids. We were getting so aggressive about trying to keep them. What was happening to the kids that we were seeing? They were dying of brain injury. They would hemorrhage into the head, or they would get hypoxic brain damage because they weren't getting enough FiO2. So we had to find a way to, how much FiO2 is safe? And the answer is, it's how much PaO2 is safe. As long as you're below 140, you're safe. And the studies that are done now, and I think it's in Britain, support that you can go to higher FiO2s as long as the PaO2 is less than 140. Some people are still pretty much adamant about not going up in FiO2s, which I'm not opposed to that as long as the PaO2 is still adequate for the brain.